can't believe how incredible the first two lectures were. We learned all about OCT, we learned all about visual fields, and then we learned about one of my favorite topics, minimally invasive glaucoma surgery. And we are in a glaucoma revolution. We are doing interventional glaucoma and taking care of patients before they have the opportunity to even take care of themselves. And now we're going to learn what taking care of glaucoma might look like a decade from now. I'm really excited to introduce my good friend, Dr. Sahar Bedrood, who's in Southern California, who's going to talk to us about glaucoma in the future.
Thank you so much, Brian. It's so great to be here and have these discussions with you guys. I'm going to go ahead and introduce myself a little bit. I'm a glaucoma specialist. I work in Los Angeles at Advanced Vision Care. And my discussion today is really going to be a little overview of what glaucoma is going to look like in the year 2030 and how I think the management of glaucoma is going to look like at that time. I expect to see 100 million people who have glaucoma. 47% of them will be in Asia and Africa. This will be a global issue, an international issue. And really we have to think about also how are people in those countries, how are doctors, how are patients going to access treatment, especially in the dawn of all the new treatments that are on the horizon. In Asia, we're looking at 18 million people who have open angle glaucoma and 9 million who have angle closure. And in Africa, we have an 11 million increase in glaucoma cases. All right, next slide. Now we have to talk about the cost. In the United States, the cost of healthcare is something that I can't even begin to explain, to be frank with you. But you have to look at what it's going to look like in 2030 and what it really looks like now. Currently, the annual cost of topical drops can range anywhere from $70 to up to $1,500 for one bottle of glaucoma medication. A brand name drop can be $1,100. A generic can be roughly under $300. And if you look at a patient, they did a study, and the citations on the bottom there, they found that patients with glaucoma have an average of $2,900 extra annual healthcare cost in their because of surgeries, because of medication, because of visits. And if you translate that to the annual cost of treatment and prevention of glaucoma, we're looking at about $12 billion in just for glaucoma in the year 2030. Next slide, please. What do we know? We know that we need more eye care professionals. We need better monitoring for our patients, and we need to understand and innovate different treatment modalities for our patients by this time. Because if you can imagine what it would feel like, or to be a physician or a patient really, but to be a physician trying to treat 100 million people in eye drops and think about the adherence to those eye drops is pretty incredible and overwhelming. Next slide. So the topic really is, what do I think things are going to look like in 2030? And I want to talk about innovation, treatment modalities, things that I think are going to be different. Let's look at today, and then let's actually backstep a little bit. 8 years ago in 2014, we were really on the onset of MIGS development. The iStent came out. And I don't know, Brian, if you were born back then, I'm just joking. I don't know if you were around back then, Brian, but it was a tough sell. MIGS was not a thing. People did not believe in it, and it took some time. And now look at us. That's all we talk about. And combination drops were newer back then. So, your Simbrinza, your Combigans were new. So that was really on the rise, and people were excited about those. And so imagine that 8 years ago, and imagine how far we've come with now and today. We not only have multiple generations of iStent later, but you have Omni, canaloplasty, you have Zen, and you have, of course, sustained delivery medications through bimatoprost sustained release. And you look at that, and you look how far we have come in 8 years, and you think about, well, where are we going 8 years from now? Part of me can't even imagine it. Next slide. But part of me, go ahead.
Before you jump there, I have a question for you.
Yeah.
In 2014, when iStent came out, were you already in clinical practice, or were you still in training?
I was in training. I was in basically the year of my fellowship, year before. So that's when it was coming out. And I trained at Wilmer. And, it was a very theoretical glaucoma, very heavy on the trabs and the tubes. And yeah, iStent was like, well, we'll think about it. It might work. I don't know, and people were really on the fence. And I think that the development and the changes and the different iterations and the different generations of MIGS devices has helped a lot.
So is it fair to suggest that you didn't implant any during your fellowship?
That is correct. Yeah, I did not. Did I? If I did, it was probably like one or two, just because, because nobody was doing it. My attendings weren't doing it. Nobody did it. So I didn't do a single one. And
then jump to the year 2020 when I did my fellowship. I did 400 MIGs.
Amazing.
And I did 10 tubes and almost no subconjunctival surgery. So you're right. Everything has changed in the past 8 years.
Yeah, and it's interesting because you did 400 MIGs and I did 300 trabs. Not joking. So that's a switch, right? And even now we have fellows and we try to teach them, and I try really hard to bring those trabs back in, right? But it's really the MIGs right now that are a hot topic. And certainly because we do so much cataract surgery, I think it's helpful to know about it and do them. But yeah, that's a really incredible point, right?
Yeah. So tell us where it's going.
Where is it going? In 2030, we're thinking, I really foresee a lot of sustained release, not just what we have now in Durista, but I think there's going to be so many other things coming out, different generations, different platforms that are going to be placed. And we're going to get so much improvement with that I think sustained delivery is going to probably take over manual drop use. I don't think we're there yet, even with what we have, but I really do think that's where it's going. Other things, remote IOP lowering and monitoring. Sorry, not lowering, but monitoring. Right now, I think patients come in, we take one IOP, maybe 3 or 4 a year, and we make all of our clinical decisions based on that. And I think that that's going to change. And I'll talk about that a little bit later. And then remote testing, of course. So let's go to the next slide. So as long as we're talking about the trajectory of how things have evolved, I always like to include this slide when I talk about innovative drugs and drug delivery systems. Pilocarpine was developed in 1875. It took 100 years to go from pilocarpine to timolol, which is actually incredible to think that it did, because pilo worked. And I think we didn't know a lot about glaucoma back then. Prostaglandins came into development in the 1990s, followed by those combination drops. Rho kinase inhibitors were in 2017. And now we're really looking at intracameral sustained release. Next slide. And there are multiple, go ahead. There are multiple ways that we're going to look at, and I'll discuss both of them. So actually go ahead and go to the next slide. Drug delivery by definition means engineered technology, targeted delivery of controlled release drugs. And if you look at it, the idea is it can come in different forms. If you look at the top screen, you'll see, and I don't know if you can see my marker here, but on the top screen here, you see the intracameral delivery. So that's similar to what we have now in Durista or Vimatopros sustained release. That's placed into the anterior chamber. Physician does it at the slit lamp or in the OR, and it elutes the drug naturally by itself over time. Currently, it lasts about 4 months or so. Then you go down and you have a different type of sustained delivery device. This is more of a docking device. So this is actually similar to where you would place the iStent, and you place it into the angle. There is an eluting membrane on the end of it, and it elutes the drug over time, again, into the anterior chamber and exactly in the place that it needs to be. Contact lens eluting drugs are very popular, have been so many different iterations of that have always tried to come out to the market. I don't know of any that are coming out now, but it's always on the horizon. And then canalicular, placing it the same way that you would place Dextenza, for example, in the canalicular area and allow it to elute over the conj over time. And then the next step, which is really not, it's like really, going into the future, but I think that's where we should be going, is port delivery. The same way that we do delivery of anti-VEGF. That is delivered every single month. With the port delivery, it's reduced down to 6 months. So I don't see quite yet why we can't get there with glaucoma drops. And, I think there might be kind of discussion of whether it's important for it to be in the AC or whether being in the vitreous might be different. But I do think this is the future of glaucoma delivery. Go ahead and next slide, please. You can advance, great. So the one that we know is on the market right now is Durysta, which is bimatoprost in a sustained release formula. It's a single administration of intracameral placed with bimatoprost. The polymer it's on is biodegradable. It does degrade over time. The drug itself is effective for about 15 weeks, but there's a subset of people for which it's effective for up to 2 years. And they don't know why it's effective for that long because there's no actual drug in the eye at that point. However, there's some loose models and theories that somehow having the drug so close to the trabecular meshwork contributes to some kind of modeling for the TM. And that's really interesting to find out kind of a little bit more about that in the future. Next slide. The 24-month phase 1/2 clinical trial of bimatoprost sustained release or Durysta. Go ahead and just press one more time, advance one more. Oh, actually go back because I think I have it doesn't have any words there. Okay, well, very good. So this one shows that our patients reduce impression lasts for 15 weeks and in a subset of up to 2 years had 20% of up to 2 years had also reduced IOP lowering. Okay, so now I'm going to show a snazzy video, which is so short, but it really illustrates the simplicity. Go ahead and go to advance to the next slide. In this particular video, you can see I stabilize the eye with a cotton swab, and then I inject the tip of the needle, and then I push down on the actuator button, and you can see it come out. It's so subtle, I had to circle it. And then it's aimed towards the inferior angle so that's where it's going to sit. Now, this was done in the OR. It doesn't have to be done in the OR. It can be done at the sit lamp. Oftentimes, I'll do one eye at a time, but both eyes at a time. A lot of people will do that as well. So, Brian, I do want to ask you, because I think this is I know that you use Durysta. How do you use this in your own practice?
This has been a huge game changer in the paradigm of how we treat glaucoma. At least in my practice, it's really changed things. So talking about the interventional glaucoma world, we know that SLT is both a cost-effective and efficacious first-line therapy. The LIGHT trial showed us that. I have started to view Durysta as an adjunct in that early glaucoma treatment. So I do all of my Durysta right at the slit lamp. The patient comes in, they put their chin in the chin rest, I put a numbing drop in, I pop in the Durysta, and they almost all say, that's it. And because it's that simple of a procedure for us to do and for the patient to go through, I think it works really nicely in the early glaucoma treatment. So I've actually been following my own little protocol that in my notes I can write the Schaefer protocol just so my techs know what I'm talking about.
Nice.
And what I do is when a patient comes in to see me, referred from either an optometrist or another ophthalmologist for glaucoma, and I do all my testing and I confirm, yes, they do have glaucoma. I sit down with them and I talk to them. I go through the model eye from front to back and I say, glaucoma is a disease of high pressure in the eye that leads to damage to the optic nerve. Our goal in treating your glaucoma is to lower the pressure in your eye. We can do that by putting medicine on your eye, in your eye, doing small lasers, big lasers, small surgery, or big surgery. And we may do all of those over the course of your lifetime. But right now, we're just turning through the table of contents and getting ready to turn to chapter 1 in your glaucoma journey. I see there being 3 main options in chapter 1. First option, putting medicine directly in the eye. That's Durysta. Option 2, doing a small laser procedure, SLT. Option 3, starting eye drops. They're all reasonable options, but when the patients hear that my first option that I present to them is getting them started by putting medicine directly in the eye because we know it's going to work right away, it's logical to them.
Yeah.
Because we know that the medicine really does last for 15 weeks, and even though there are the subset that last longer, I only rely on that 15-week period because you don't know who's going to be in that subset that lasts longer. Right. So I actually do a planned SLT at the 3-month mark, because I know that at 3 months, the medicine is still working fully, and it's going to take about 6 weeks for the SLT to fully ramp up. So instead of bridging them with a drop, I use this opportunity to have Durista in the eye and bridge their IOP while the SLT takes effect. And ideally, that's going to push them out on their IOP lowering journey without drops for as long as possible. And I'm collecting data on it, and we'll see how it goes.
Yeah.
How about you? How are you using it?
Yeah, I use it in a lot of different ways. Mostly for me, it's to improve the ocular surface. So for me, it's a little bit different of a presentation. I don't use it as first line therapy, but I will use it in patients who are currently on something and don't tolerate it or need a drop vacation. I definitely like to use it for patients who I'm planning on a MIGS procedure like a Zen or even a TRAB, and I want to really optimize the ocular surface. It's even really great for patients who are undergoing cataract surgery, who have that really terrible dry eye, poor ocular surface, bad MGD, and they're on these drops, and you're like, well, I can't take you off the drops, but you can, because you can do this. This will optimize, then you'll get really good measurements of the eye, and then they can have surgery, and then when you do surgery, you can actually just take out the implant with IA, and you're done. And, I know that this is a CE primarily for optometrists. And that the question and an answer that I put out to them is, when do you refer to for sustained release? And it's on all of those reasons. Patients who want to drop vacation, people who are not, maybe did SLT and it didn't work, or who want SLT. I think using it a few months before SLT is brilliant. And that's a really great way to extend the time in which patients don't need to use the drops themselves. So.
Yeah, and I think that the big key, and it even shows itself in just between our two practices. You have a more mature practice than I do. I'm about a year into my clinical practice, so I'm seeing a lot of glaucoma suspects who are maybe just converting to glaucoma for the first time. Yeah. Whereas you have some more advanced glaucoma patients that you know how to manage better than I do. Yeah. So that's going to be relevant for all of the optometrists on this call. It depends on what stage of glaucoma and who the surgeon or who the ophthalmologist you're referring to is and what their clinical practice is like. So if these are brand new patients, you may have patients who come back with a Durista or an SLT, and that is totally relevant first line therapy now. Whereas even just a decade ago, even SLT didn't have high adoption rates.
Absolutely. Great. All right, next slide. So that was the only one that's FDA approved currently, but there are so many things on the market coming out in trials in different phases of clinical trials. One other one is sustained release iDose TR. So this is different than, it's not just implanted into the AC, free to float around. This is actually docked into the trabecular meshwork. It's a titanium implant, very similar to the iStent, and it is for continuous drug delivery of travoprost across a membrane. This has a really long duration. First of all, it's implemented surgically. So we have to take the patients. It won't take a whole long time, but you still have to lay them down, use a gonio lens, and implant it the same way that you would the iStent. But it lasts up to 2 years, which is really great. And there are some versions of this that have shown even longer efficacy. Phase 3 clinical trials are underway. And the cool thing with this is you can actually remove it and then exchange it for a new set of that's filled with drug again. Go ahead and next slide, please. So this is a video of the placement of iDose TR, and you can see here it's very similar in the fact that you are going to use a gonio lens. You implant it directly into the TM, you let go of the implant, and then you pull right back. And it is a little bit larger than the iStent. It sticks out a little bit more because you actually need it to. It has an eluting membrane, and all the drug is actually in that little space. But you can see that it is relatively straightforward. Go ahead and advance the slide, please. So iDose, the US multi-center phase 2B trial, 36-month outcome, found that if you compare the iDose fast eluting, which is in the light blue, compared to the slow eluting, which is in the green, to timolol, they are very similar in efficacy. And I think that they have gone out to about 3 years and have found that there is a reduction at 36 months, which is pretty incredible, actually. Next slide, please. Future drug delivery systems include the iDose TR and iDose TREX, and that is basically going to be Rho kinase inhibitors. I'm personally excited about that because I know that rho kinase inhibitors do a fantastic job of actually lowering the pressure. They don't do a fantastic job of being on the eye. Personally, there's just a lot that I have to deal with as far as the ocular surface. So actually being in the eye, I'm really curious what the results will be for IOP lowering and for overall health of the eye. Next slide. Next on our list is another intracameral injection. This is by Ocular Therapeutics. It's an injection of travoprost. And you can see here that it is going to be placed in very similarly to the Durysta. And it is, you can see here it's outlined in yellow. I don't think it's going to be yellow in the actual formula that they're going to use clinically, but and it elutes again over a 4-month period, 4 to 6 month period, and those investigations are also underway. Next slide. Great. Can you go one more slide ahead? I'm not sure. I think I have some words coming. Okay, no, go back. All the way back. There you go. Pipeline. Perfect. So here we are. We have the pipeline of things that we've talked about and what I think is coming out. We talked about the potential of port delivery in the future. The image on the bottom is are basically liposomes with latanoprost inside, and it's injected subconj, and then it just elutes under the conj over several weeks to months. That's something that is also discussed. Canalicular implants is very popular. Again, I don't know how much of the surface issues that's going to solve or worsen. We've got to see it when it comes out in the clinical trials. And then a contact lens eluting. Again, there's pluses and minuses on that because it's difficult for our patients in the 80s or patients who have glaucoma to be putting in contact lenses. But it may really be a great option for some of our other patients who are either already using lenses or are younger and are okay with placing this in themselves. Next slide. So what do we learn? What do we think about? When I think about glaucoma in 10 years, I think about the paradigm shift of discussions with patients are going to be completely different. I think that we were so used to talking about just placing drops on the eye, go home, see you in 3 months, see you in 4 months, come back, do a visual field yearly. And I think that that's going to sincerely change. We are looking at getting better adherence to drops. If we get better adherence, we hopefully can get better control of the IOP and also less progression on the visual fields. So that's definitely better for the patient. 24-hour control versus this dose control where you place a drop in, they have control for 4 or 5 hours, the IOP spikes, we don't know about it, and then goes back down. This is going to be in the eye, so it's 24 hours, much like a surgery or a stent or a tube. And then it might be an overall lower cost to the patient because they're not using their Part D Medicare, or they're not using their pharmacy benefits for this. This is a medical procedure, so it would use that. Now, they might have to pay more on that side, but hey, that's a different discussion, right, Brian? But so what are the negatives? The negative is, honestly, I think a big part of this is going to be a paradigm shift of how we have discussions, how our conferences go, how we talk to the patients about what we do next. Where, we still, I think a large majority of people still offer drops to patients as first line, even though there are studies that say SLT can be equivalent to using a prostaglandin. So those discussions will change over time. There's going to be more chair time, having to talk to patients and tell them, I'm going to implant something into your eye or place something in your eye, is a little bit jolting, I think. And that, again, is going to change the way we talk about it and talk to patients. And then overall healthcare costs. Look, the truth is these things are not cheap. They weren't cheap to develop. Durysta took 15 years of research to develop. So yes, the implant itself probably right now is not going to be cheap to the consumer, to the insurance companies. And so that is something that has to be thought about and implemented, because if it's going to increase our healthcare costs, then that might be a problem. But those are some of the negatives and some of the things that we think about, that I think about when I think about this new technology. Next slide, please. So we're going to move away from the sustained delivery and talk a little bit more about what I think is going to be in kind of more of a clinical setting. And What I know for sure, I'm going to talk about these 3 points. Remote IOP monitoring, contact lens monitoring, and artificial intelligence are going to play a role in the future in some way. Next slide. Let's talk about eye care home. I don't know if you use eye care home or do you send it out to your patients or not? Do you, Brian? I don't know if you do.
Yeah, I do actually. And I think that it's extremely helpful, especially in patients who we label as normotensive glaucoma patients who really they're not. They're just spiking out at the office.
Yeah, absolutely. I think that you would be surprised to find what the actual IOPs are of patients who monitor it over the course of a full day and evening. But eye care home, now this certainly is not something in 2030. We have that now. It's FDA approved. The physician has to order this, and then the patient buys it from the physician's office. And I only know this because I just went through this because a patient of mine wanted to purchase this. They live internationally. It was difficult for them to come to get obviously an IOP check. So they wanted to be able to use the eye care at home and then report their results to me, via email, which I was like, that's brilliant. That's the way to do it. But I think that this is going to be more common. I think that there's going to be there's already really great data and software that's coming out showing, how to put it into a cloud system so that it can be downloaded and then the doctor can take a look at it. And it's, of course, 24-hour monitoring would be great, and then transmitted to a portal. The negatives for this are that it's the patient has to use it, right? So we have to make sure it's accurate. Otherwise, all the pressures we're getting and all that effort is going to be wasted. So a little bit of training would have to go into making sure that the patient is trained or a caregiver is trained. Next slide. Other things that I've heard and I've seen people talk about is contact lens IOP monitoring. The first one on the top is called Triggerfish. Triggerfish, now they technically, if you look at their website, they will not use the word IOP. So it monitors changes to the volume of the eye and the corneal surface changes. And I think that by monitoring those changes, perhaps it reflects a change of not just the volume, but how much pressure is inside the eye. And then there's another contact lens, which is really in early diagnostic phases, early scientific studies showing a sensor on the contact lens. You can see it down there. I don't think it'll look like that, but they'll make it more fancy at some point. But it also has an in situ delivery of drug within there. So when it senses the pressure going up, perhaps it delivers it. And I think that's where the future is. That's where we're going to see it. I don't know if it'll be there 8 years from now, but I bet you will be there 15 or 20 years from now, where this is going to be using a lot of artificial intelligence and remote monitoring. Next slide, please. And then here, this fancy device here, I thought at first that this was a visual field device, but in fact, it is not. It is basically using artificial intelligence. It measures the IOP. So you place it on your eye, and it uses analysis of the vascular pressure to tell you what the IOP of the eye is. It's contactless. It's performed in 3 minutes, and the patient has to wear it, and then it's uploaded automatically to a cloud. And again, I think that this is where it's going to be going, where we have contactless or either contact lens or contactless. And we basically monitor remotely, because this whole idea of checking your pressure once a year or twice a year, that is going to be obsolete at some point. Next slide, please. Oh, my summary didn't come up, did it? Okay, so great. Well, I'll just leave it at that. The summary really is, and most of it's going to be addressing questions and a discussion with you. But I think that the thing that we need to think about is right now we have sustained delivery systems. We need to start thinking about ways to implement them, to talk to our patients about reducing the drop burden for them and getting the drops out of their hands and into ours so that we can treat them most effectively. So that's really where I see sustained delivery going. And as far as IOP lowering and artificial intelligence, that is a whole lecture on its own. But I think that the future of glaucoma is going to be so technically savvy that it's going to be remarkable. And I can't wait to see it one day.
Thank you so much, Sahar. That was phenomenal. And it makes me so excited that I'm in the glaucoma space. You know, even when I was early in residency, dry eye was the only sexy space in ophthalmology. But now glaucoma's sexy. And it's because of things like this, all of these future innovations that are happening. And, you know, when you're talking about sustained drug delivery and even down to like the PDS, the port delivery system for ranibizumab, Susvimo, it makes me think about the parallel between glaucoma now and retina 15, 20 years ago. And I've even asked some of my older retina partners in my practice, what was it like when anti-VEGF came on the scene? And to them, it felt like malpractice to stick a needle in the eye for somebody with abnormal blood vessels.
Yes.
Everybody with abnormal blood vessels got a laser, period.
Yes.
Now you don't walk through the door without getting a needle in your eye if you're going to a retina practice.
Oh, absolutely.
And I think that we're catching up. And one of the challenges that I believe we face in glaucoma is that we don't have protocols that can drive our decision making. It is very much an artistic field. It is almost still the Wild West in that everybody does something different. Yeah. Whereas if you look at the DRCR in retina, they're on protocol, I think they're on protocol AM at this point because they've gone all the way through the alphabet and now they're going back through the alphabet because they have so many data-driven protocols that guide their management. And I wonder if we'll get there.
I do wonder. And, you know, I don't know if we will, because everyone diagnoses it differently. First of all, everyone manages it differently. Some people manage it based on a visual field. Some people do it via OCT. Some people do it purely by pressure. And what do you do about our myopic patients who we can't really assess the nerve? And it's truly just looking at either fields or IOP. And I think that that's where the art and the discussion and all that chair time comes into use when you're dealing with glaucoma patients. And I've personally changed a lot of my management. I really do this customized care because patients will come in and you can see all the side effects of all their drops. And, you know, I think that 10 years ago, we're like, oh, well, that's just glaucoma drops. There's nothing we can do for you. But I think it's totally out. Like I see that and I just go through a list of all the things that I can do for them that takes those drops out, that helps them get their ocular surface back and gets their pressure down and intervenes a little bit earlier. So those are some of the things that I kind of just think about right off the bat that are so different than what I learned in residency.
It's very interesting. It begs the question, what is controlled glaucoma anymore? Because historically it was just, if your pressure is controlled, your glaucoma is controlled.
Yes. Yeah. And I think that we know that pressure is not the only thing, right? We know that because we have normal tension patients who have low pressures. And we have patients who, you know, I have patients who I've operated on or have been operated on 20 years ago, and they still progress despite a pressure of 8. So glaucoma, IOP is not the only thing. There's so much that needs to be discovered. And I think that, I hope we don't look back and say, God, we were idiots back then, but we might, right? That's just, you know, there's so much we don't know and we just base it on pressure.
It's true. And even down to our OCT technology, it was so groundbreaking when we could start measuring nerve fiber layer thickness. And then we're like, oh, well, actually the nerve fibers are coming off of the ganglion cells, which die first, and then the nerve fibers die. So maybe let's look at the ganglion cells.
Exactly.
And are you familiar with DARC technology, DARC?
Yeah.
This, I think, is one of the biggest things that if they can get the technology right and like easy enough to do, will be a huge game changer. DARC, I forget what it stands for, but essentially it's where they inject you with something. It's like almost like getting a fluorescein angiogram. And you can see how much of that tracer is taken up by the ganglion cells. Mm-hmm. And the amount that's taken up by the ganglion cells shows you the level of stress of those ganglion cells. So it doesn't just show you cells that have already died or cells that there's attrition of the nerve fiber layer. It shows you cells that are actively dying.
Yeah, so, amazing.
it would be amazing. And this is currently pretty much only in use from a
You
research.
know what? Actually, I think that I was part of a talk for for that. Now that last year someone presented it. It's very early technology,
It
early
is
phase.
very early, and a lot's happened over the past year or so, mostly in the sense that awareness is starting to happen, and that's a good thing, because the more awareness of these types of things that happen, the more we can get this technology available to our patients.
Yeah, absolutely. Awareness, teaching, thinking differently, and all of that's going to change. I think that we're going to learn a lot about glaucoma in the future.
So in the year of 2022, we've had two new MIGS devices released. We have iAccess and Streamline.
Yeah.
Is this going to be the new normal? Every year there's a couple new MIGS devices that get released?
I know. I wonder about that. Even now, it's incredible. I mean, I certainly hope so. I mean, look at that. Like even within the iAccess and Streamline, there's enough difference between them that I would use one for one type of patient and one for another. I think so. I mean, I think that it's going to go through phases. I think there's going to be, right now it's like a big MIGS and angle surgery kind of push. I think that the next step is going to be diagnostic and imaging. And I think that a lot of and then the future really is going to be neuroprotection and how do we protect the nerve and also do IOP control at the same time.
Yeah, very, very interesting. And I wonder if we're getting any closer to understanding what glaucoma even is, right? Is it a one pressure disease? Is it a two pressure disease?
Yeah.
I think a lot about what's actually happening right there at the lamina cribrosa. It's a two pressure system. Your IOP and your ICP are meeting each other right at this thin layer of tissue.
Yeah, absolutely.
There's
I did a study when I was I know we only have a few minutes left, but I did a study when I was in fellowship at Wilmer, and we looked at that lamina cribrosa. And the theory for, with like Dr. Quigley and Wilmer is really like glaucoma is a mechanical disease where it is IOP pushes stress on the collagen and on the nerve, and then somehow that creates apoptosis and the cells die. And we looked actually at the lamina cribrosa specifically in patients with advanced disease and early disease. And we found in an early disease, the lamina cribrosa would move. And in advanced disease, it was stuck. It was almost like it was already kind of oxidized and not moving anymore. And I think that those are just things that we're going to continue to learn about. And again, look forward to seeing what we have, what you're going to discover, Brian.
Yeah, right back at you. This was so fun, Sahar, and I think we're gonna wrap it up here. But I can't wait to see you soon, hopefully. And thank you for sharing all of your insights and being the oracle that tells us what the future looks like.
Oh, so fun! Thanks again, and thanks for the conversation. We'll see you later.